Welcome, everyone, to the 2025 NCCI Edits and Manual Updates, presented by Vanessa Youmans, COO of Yes HIM Consulting. For today's webinar, you are in mute mode. If you have any questions or concerns, please post them in the Q&A section. We will be monitoring the Q&A section throughout the webinar. The chat feature is disabled. We have sent an email this morning with a link to download the webinar slides. There is also a link to the slides that will be posted in the Q&A section. After this webinar, we will talk about how you can access a CEU Certificate of Completion. A little more about our presenter, Vanessa. Vanessa Youmans is the Chief Operating Officer at Yes HIM Consulting. Vanessa holds a Bachelor of Science in Mathematics from St. John's University and a master's degree from New York University. As COO, Vanessa oversees multiple critical areas, including inpatient, outpatient, and professional fee coding and auditing services. Her credentials include RHIA, CCS, and CPC. Vanessa, take it away.
Thank you so much. I just want to take a second and thank everyone for joining us today. Today we're going to be talking about the NCCI edits and the manual updates for 2025. I know most of us probably don't have the chance to really dig into those NCCI edit tables and see what's really changed. They may be a little bit overwhelming, and that manual too, it may be a little difficult to go into that in detail. So that is what I did for all of the 2025 updates. So just to take a second, I want to make sure we're all on the same page with what NCCI edits are. And when we're talking about NCCI edits, those are the National Correct Coding Initiative edits for procedure to procedure. So that means we're talking about CPT codes, and those edits prevent any inappropriate payment of services for procedures that should not be reported together. And when we're talking about edits, usually we're talking about a modifier can be used to resolve the edit, or sometimes the NCCI edit tables tell us that no modifier can be used, and those two particular CPT codes can never be used together. So again, we're kind of talking about CPT codes, and two sets of procedure codes on the same day, can they be used together? So here at Yes, we do have a disclaimer at the beginning of each of our webinars, but I'll breeze through that. So the agenda today, when we talk about NCCI edits and modifiers in general, we got to talk about modifier 59 first. And when I say modifier 59, we can of course mean the X modifiers as well. But I always think it's good to have a baseline of when do we use modifier 59? When is it appropriate with these edits? When is it not? Then we'll really take a deep dive into the NCCI edit tables themselves, the changes, the additions, and the deletions. So those particular tables can be a little bit overwhelming, like I said, because a lot of those additions and deletions are truly just the codes that were deleted or the codes that were added for that given year. But what I really wanted to look for in those edit tables is what was removed or added or changed, or what I call true changes, deletions, and additions from codes that were with us in previous years. So something that maybe you're used to coding a certain way that might be a little bit different. And then we'll dive in a little bit into the actual NCCI manual and what was updated there. And I do just want to have a note for the NCCI edit tables. I'll make a note about the practitioner versus the facility edits and which ones apply to which. There is only one where it's only a practitioner edit, but I'll get into that a little bit later. So let's talk about modifier 59. And of course, when we talk about modifier 59, We could also be talking about the X modifiers, right? That you can use in place of modifier 59, which is XE, XS, XP, and XU. So let's talk about modifier 59 or those X modifiers. When do we use a modifier 59? And no, if you're thinking to yourself, oh, I can just use it when there's an edit. That's not the right answer, right? We don't want to just slap a modifier 59 anytime there's an edit. So there's a really great reference that I have on the reference slide when you download the slides. It's something that CMS has published. It's MLN number 1783722. And it's really a great hands-on guide. You can save it onto your desktop anytime you need to look at it. When you use modifier 59 and when you really shouldn't. The biggest thing with modifier 59, and we have a great teammate here at ES who always uses these words, and I think it's such a great thing to think of when you're assessing whether or not you should add a 59 to an edit. And she always says, listen, modifier 59 is a case-by-case basis, and that is so true. Modifier 59 should not be used on every case. It really should be in scenarios where it's a little bit different, and it really has to be within the documentation. So some things that the MLN, like I said, 1783722 states is that you really want to look for something in the documentation where that procedure is performed in different anatomic sites or organs. Maybe it's performed on separate encounters on the same day. Maybe your one surgeon does something in the morning, then a different surgeon does something in the afternoon or something like that. Separate non-contiguous lesions is another one, or even separate injuries. So you may be saying to yourself, when should we not use the modifier 59? Okay, so this MLN says when another more specific modifier is appropriate, they say if there is a more appropriate modifier to always go with that versus a modifier 59 or the X modifiers. You should not use a modifier 59 simply because the code descriptions are different. You shouldn't use a 59 for procedures in contiguous structures in the same anatomic region. And of course, like I said, just to bypass the NCCI edits when criteria aren't met. And really, like I said, it's a case-by-case basis. When there is a modifier 59 involved, you really have to take a second and look at that documentation and see if that modifier 59 is appropriate. So let's look at the actual NCCI edit tables. And the first category we're going to look at is any changes. So what that means is maybe last year it was on the NCCI edit table, but maybe it required a modifier in the past, and now they're saying it's never allowed even with a modifier. So let's look at the first example, and I actually think this one is pretty interesting because I can't imagine that this would happen very often, but they are so diligent with their NCCI edits and they take such care in reviewing these changes. And you'll see there's only a handful of actual changes. There has to be a reason why this was done. It may happen. It may be two different procedures on the same day or something like that. So this is a change that was talking about codes 44160 and 44140. Last year, this was not allowed even with a modifier. So it was one of those two procedures that if these two were coded together, you could never code it. You would have to pick one, right? So now it is allowed with an appropriate modifier. So let's talk about the procedures. The first one is 44160, which is a colectomy, a partial colectomy, with removal of the terminal ileum with an ileocolostomy. Okay, and we'll talk a little bit about where the ileum is. I did highlight that area. It's right next to the yellow area in my little picture over here. And what the physician does is they make an abdominal incision and remove a segment of the colon and terminal ileum. And after that, the physician also performs an anastomosis between the remaining ileum and the colon. So what's interesting about that is this procedure actually includes an anastomosis. So 44140 is also a partial colectomy with an anastomosis only. So in this procedure, the physician resects a segment, all it says is a segment, so it could be anywhere on the colon, and performs an anastomosis between the remaining ends of the colon. So I would imagine, like I said, I would really like to see documentation where this would be appropriate to add both CPT codes and modifier 59, because the 44160 really includes an anastomosis for that section of the colon. So if the provider really truly is working in a different area of the colon, perhaps, or like I said, maybe it was a separate session during the same day, something like that. That's the kind of documentation you would want to see for actually coding both of these separately. If the provider is only doing 44160, that partial colectomy with the removal of the terminal ileum and an ileocolostomy, an anastomosis is included in that procedure. And just kind of a note, both of these codes are actually currently an inpatient only procedure. So this is not something that you would probably see on the outpatient facility side. You would more likely see it on the professional side, but in terms of edits, they did add it to both the facility and the professional side. I do just want to take a minute before we switch to this next case here. I did just want to remind everybody that the NCCI edits do have two separate sets of edits. There's one for the facility side and one for the professional side. And like I said, all of these except for one are for both, but I just wanted to make that clear. So this is really interesting, and we're going to talk more about cystectomies and how they now include urethrectomies. And this is one that is only going to be a change. So this is 51595 and 53210. And this is now not allowed with any modifier. And like I said, this is going to be a cystectomy procedure with a urethrectomy procedure. And like I said, we'll talk a little bit more about this on the additions category, because this was a big change for 2025. They actually went through and took out all the urethrectomies, and now you're not allowed to code it with any modifier to the entire series of cystectomy codes. So this particular one was actually allowed last year with a modifier. But now that they've gone through and made those changes that we'll talk about a little bit later, they did include that with this particular two series of codes. So this is now not allowed with any modifier either. So this is a complete cystectomy where they actually remove the bladder and they create a ureter ileal conduit going toward the skin. So it actually diverts the urine by connecting the ureters to that conduit, and you can see that in the picture on the right-hand side with that opening to the skin. And what they are saying now, that all of these cystectomy procedures really include that work for the urethra being removed by the physician, which is going to be that 53210. There is also a code for 53215 if it's a male-specific procedure, which will also now be included. So I thought that was an interesting one. And again, we'll talk about that a little bit more when we talk about how all of those are now not allowed with any modifier. So this one is now allowed with an appropriate modifier. This is magnetic resonance angiography, an MRA. And this is actually a special type of MRI, and it really specializes in visualizing blood vessels and blood flow. And it evaluates vascular disorders within the structure being studied. And a lot of providers like to use this because, unlike a CT, it does not rely on the absorption of X-ray energy. Previously, if this was coded with 76376, which is the 3D manipulation of data sets and image rendering, it was not allowed even with a modifier. Now it is allowed with an appropriate modifier. And like I said, with things like this, you would really want to see good documentation that these are indeed separate. Now we have two debridement codes. This previously was not allowed even with a modifier, but now it is allowed with an appropriate modifier. And when we're talking about debridements, you would really want to look for those separate sites or separate injuries or something like that to be able to add an appropriate modifier to resolve this edit. So 97597 is an open wound debridement. It's per session, and it goes by total wound surface area. And now they're saying if you have 97602, which is the removal of devitalized tissue using a practice called non-selective debridement. So what is non-selective debridement? These are techniques that really remove devitalized tissues, and non-selective debridement techniques are those in which necrotic and healthy tissue are removed. So you may have heard terms like mechanical debridement, wet to moist dressings, autolytic debridement is another one, abrasion, and larval therapy. So again, you would want to look for something like this is on separate sites or injuries, and now this is allowed with an appropriate modifier. So wrapping up the changes, we did have two column changes, which I thought were kind of interesting. So the next two codes here, there was a column change. So we have 29876 and 29882. So previously 29876 was the column 1 code and 29882 was the column 2 code. So what that means in NCCI language is generally when those two codes are coded together, 29876 would be the primary code in terms of reimbursement, and 29876 would be the secondary code for reimbursement. And usually our encoders would tell us, okay, that means 29882 would be the code where you would add your appropriate modifier because it was the column 2 code. So what happened this year is they actually switched it. So now 29882 is going to be the column 1 code. And that is your arthroscopic knee surgery with meniscus repair, medial and lateral. And now they're saying the 29876 code should be the column 2 code, which your encoders will now switch and tell you to add your appropriate modifier to the 29876 code, which is your synovectomy code. So if you're not aware of what a synovectomy is, that's really the surgical procedure that removes the membrane that lines the joint. And I do have a little diagram here to the right, and you can see that little reddish outline in the picture there, where the capsule of the joint is. You can see the red on the outside. That is really where they are removing that synovial membrane during that procedure. So they're really considering that if you're doing a meniscus repair, they're considering the synovectomy the secondary procedure. So if you're someone who codes these a lot, maybe you're at a ambulatory surgical center, or you're in the professional fee setting and you work for an orthopedic doctor, and you're really used to adding the 59 to the 29882, just keep in mind that those two did switch. Your encoder should act accordingly, but I did find this to be interesting. The last for the changes, I honestly think that this should have always been this way. I think it was one of those things that maybe they didn't realize and have now corrected it to a way that at least makes more sense to me. Again, this is another column change, and we're dealing with two codes. The first one is just a simple repair of a blood vessel in the neck. And then the second one, which used to be the column 2 code, is a thromboendarterectomy, including a patch graft for the carotid, vertebral, or subclavian by neck incision. So that's a big surgery, especially compared to a repair a blood vessel. The 35301 actually is where the physician makes an incision in the neck and finds the carotid, the vertebral, or subclavian artery. After the plaque and lining are removed, a patch graft may be applied and sutured to the vessel, and this in turn enlarges the diameter of the artery. So again, that's a pretty big procedure to be a column 2, and especially when the repair blood vessel is really just to find the vessel and repair it and do a layered closure. So they did go ahead and switch column 1 and column 2. So again, if this is something that you see fairly often in your practice and you're used to appending a modifier to a certain code, just something to look at. Okay, so now we're looking at the deletions, and actually there were 0 this year. So there are no deletions where you had to look for an appropriate modifier, and you no longer have to this year. So we can move on to the additions. So here we are at the big addition that I was talking about a few slides ago, where all cystectomies now include a urethrectomy. And the cystectomy CPT codes are the series 51550 through 51597. So if you're following along in your CPT book, or maybe some type of encoder, it's 51550 through 51597, and they now include all urethrectomy codes. So that is 53210 for the female and 53215 for male procedures. So I just put one example here. This is a complete cystectomy, and the provider also did urethrectomy, and this is now not allowed even with a modifier. So they consider this completely inclusive. But there are lots of other code combinations because the cystectomy code series is pretty long. So just keep this in mind, especially if you see a lot of urinary system type procedures at your facility, or if you're working with a practitioner. This is an interesting one you probably don't see that often, but I did find it kind of interesting. So this is an insertion of phrenic nerve stimulator system. So where's the phrenic nerve? And I actually put a diagram on the right-hand side there. The phrenic nerve comes from your cervical spine through C3, C4, and C5. So what the provider actually does is they insert a stimulator system into the phrenic nerve, and it actually includes a pulse generator containing electronics and a battery, and one stimulation lead. Now they're requiring a modifier if you are doing a 63685 procedure. So that means if you're doing an insertion or replacement of a spinal neurostimulator pulse generator, receiver pocket creation, and connection. So what they're probably thinking about with this NCCI edit is just making sure if you're doing an insertion for a phrenic nerve stimulator system that you're also not adding the 63685, and you would really need to add an appropriate modifier if you're putting another one into a different body part. So again, we're going back to the definition of modifier 59. Is it a different body part, a different site, something like that? And this is the example I was talking about. This is the only addition to the NCCI edits this year that is practitioner only. So this does not apply to the facility side. And this is actually where the same insertion of the phrenic nerve stimulator system, it now requires a modifier for 61650. And 61650 is actually an endovascular intracranial prolonged administration of a pharmacologic agent. So that means that it's actually the administration of the agent. So that's probably why it's only on the practitioner side. But what happens is the practitioner has a catheter equipped with an infusion tip, and it's threaded into the vessel, and the catheter travels to the intracranial vessel, and drugs are infused that way. So again, it's one of those things that they want to make sure that it's completely separate from the insertion of the phrenic nerve stimulator system. So again, those last two you probably don't see too often, but I did think it was fairly interesting that they were added. Okay, so let's talk about NCCI Manual. And I always hear a lot of discussion when it comes to the NCCI Manual. Is it something I should be using? How many facilities use it? How many practitioners use it? So the NCCI Manual is generally accepted as a practitioner professional fee type document, and it really truly is a long document. I always compare it to the tax law. You really have to know the ins and outs of it. But it is something that a lot of facilities reference as well. Some of our clients expect their coders to also know the ins and outs of the NCCI manual, while others of our clients say the coders aren't responsible for the NCCI manual. We want them to follow the NCCI edits within the encoders. And if anything else falls out, we'll work denials or set policies for the coders to follow or things like that. So if it's something you're unsure about, if you should be using at your facility, I would check to see your individual policies at your facilities or your clinics or wherever you happen to be working to see if it's a policy that you should also be following this as well. For the most part, within the NCCI manual, there are general guidelines that are generally accepted that facilities also follow, of course, but there are also some listings in there that are specific. And we'll actually see there was a change in the I system category that is very specific that may not be captured in the NCCI edits that you may need to know. So it's always good to check on your individual policies and how your facility or your clinic would like for you to handle this. So in terms of changes, there weren't a ton of really lengthy changes, but there were a lot of useful, what I would say, clarifications. So the first one is that, and this is something we really kind of knew, but it's always nice to get these things in writing, right? So they went ahead and said that modifier 22 is not an NCCI PTP associated modifier. So what does that mean? What's a PTP associated modifier? That is really where it resolves the edit. So it confirmed that modifier 22 is not an NCCI PTP associated modifier. And then they also added modifier 22 to what was already there, modifiers 76 and 77, which are those modifiers for additional procedures on the same day. And modifiers that may be used under appropriate clinical circumstances too, they use the word bypass. I always like to say resolve. And NCCI PTP edit include, so we talked about modifier 59 in the beginning, but don't forget there's tons of other codes that would be more applicable. So in the beginning, when we talked about that MLN, one of the biggest guidances they have is don't code modifier 59 if there's a more appropriate code. So don't forget about your anatomic modifiers are great. Your E1 through 4s, your F1 through F9, all of those. And then of course the LTRT, and then you of course have those LC, LD, RC, LM, RI for the cardiac procedures. Don't forget about those. And then we have the global surgery modifiers. That, of course, is more of a practitioner concept or a professional fee concept, but don't forget about those, the 78, 79, 24, 25, 57, 58. And then other modifiers like 27, 59 we talked about, 91, and then, of course, the X modifiers. I did just want to say, in my experience, usually modifier 59 versus the X modifiers, in my experience, it has been a facility or clinic by clinic policy on which ones they use. Sometimes it's in the payer contracts per facility. Sometimes it's just a facility policy. So if you're unsure if your facility uses 59 or the X modifiers, that would be another thing that you could check on to see, should we be using these X modifiers or are we going to stick with modifier 59? This next one was very interesting because, again, it wasn't anything new per se. It was something we all had kind of figured out, but it was great to have it in writing finally. It's great to have a little bit of clarification. So let's talk NCCI edits versus CPT assistant, okay? And discrepancies, and we have been finding them. And it's a little bit hard to navigate when the NCCI edits or the NCCI manual conflicts with CPT assistant. What do you do, right? So there was a little bit in bold there that was added. So the following statement has been added to the NCCI manual. The AMA publishes CPT assistant, which contains coding guidelines. CMS that publishes NCCI edits and manual does not review or approve the information in this publication. This is what was added. As a result, CMS may adopt NCCI edits that are not consistent with CPT assistant. If a physician uses information from CPT assistant to report services rendered to Medicare patients, it is possible that MACs may use different criteria to process claims. Whew, that's a lot. I'm glad we have it in writing. But again, what do we do when it conflicts, right? What if there's an NCCI edit that directly conflicts with what it says in CPT assistant? So this is my and Yes's recommendation for how to handle that. There's a couple ways you can handle it. The first one is just with a general facility policy. You have a work group who talks through it. Maybe you have somebody from compliance come, maybe you have a physician liaison and coding experts. You bring a group together and come up with a policy. Another option is to contact your local MAC directly. So in the state of Florida, you can send First Coast emails and get a response. So you know 100% for sure how the MAC is approaching the situation. Another option is you can contact the AMA directly and get a response from them. You may get a similar response in that the AMA does not review NCCI edits, but it's always worth a shot. And then, of course, you can do a little bit of a combination of that. But I definitely would recommend, if there is a direct conflict, to have some sort of policy in place or some sort of instruction to your coders, to your physicians, so everyone's on the same page. Now, XXX procedures, that was the next item in the NCCI manual that was updated, and I bolded the portion that was updated. So what are XXX procedures? Again, this is a practitioner concept, and when we're talking about XXX procedures, we're talking about global periods. So the Medicare physician fee schedule will say how long a global period, meaning when everything is inclusive, right, for each procedure. So if you have a major procedure, generally the global period would be 90 days. So your follow-ups and things like that would be part of the global period. Versus an XXX procedure basically means that the global period doesn't really apply. So what did they change? They included that performing a significant and separately identifiable E&M service that is above and beyond usual pre- and post-operative work of the procedure on the same date of service, which may be reported by appending modifier 25 to the E&M code. So what they really clarified for us is the additional information there about pre- and post-operative work. So in order to bill an E&M service, and again, we're really talking about the practitioner side, to really bill a significant and separately identifiable E&M service in addition to the XXX procedures, you really need to have work beyond the procedure plus the pre- and post-operative work. So that was a little bit of the clarification. Interestingly enough, there aren't a ton of XXX procedures. One example is an X-ray, for example. So there's not a lot of pre and post-operative work, but I thought in general that was a very good clarification to make, that when we're billing these E&M codes with any procedure, I think it's good to really look at, is it beyond the pre and post-operative work of the procedure on the same date of service? So I thought that was a good clarification there. Another global period aspect that we got a little bit of additional clarification, and I believe this was on a modifier 24 or a global period fact sheet I had seen published by CMS, but I was super happy to see it actually added as a clarification into the NCCI manual as well. And that is really, so modifier 24 is to resolve the global period edit. So say a patient has a major surgery, the Medicare physician fee schedule says it's a 90-day global period, but the patient comes back into that same provider and say something else happens or another issue arises. That E&M service generally can't be billed because of the global period, but if there's a separate issue, it can be billed as an E&M with the modifier 24. And that modifier 24 is unrelated evaluation and management service by the same physician or another qualified healthcare professional during a postoperative period. So what they added to that is, and I'll read that whole sentence, postoperative visits, it's kind of in the middle there, postoperative visits unrelated to the diagnosis for which the surgical procedure was performed, unless related to a complication of surgery, may be reported separately on the same day with that modifier 24. So what they added was, unless related to a complication of the surgery. And again, I had seen that floating around on some CMS published cheat sheets for global periods and modifier 24, but I hadn't seen it in the NCCI manual yet. So I'm glad they added that clarification that you cannot bill for an E&M level if it's for a complication of the procedure that the patient had. That is inclusive. Okay. So the only actual specific, and like I said, if you've never looked at the NCCI manual, it's chapter specific. So there's a chapter just for the 10,000 codes. There's a chapter just for the 20,000 codes, and it goes into a lot of detail. They're pages long, and it says what's included for each of the body systems. So the only chapter specific clarification that is in the NCCI manual for 2025 is regarding the eyes, like I've said before. So this is about a cataract extraction. And if an iridectomy or vitrectomy that is separate and distinct from the cataract extraction is performed, and then they added for an unrelated reason at the same patient encounter, that procedure may be reported separately with an NCCI PTP associated modifier, which we know now. A couple slides back, we went over all of the modifiers that would help resolve the edit. And then they also added the medical record must document the distinct medical necessity for each procedure, which I thought was kind of interesting. I mean, generally, we should have for all of these, if we're adding a modifier 59 or doing some other type of modifier to resolve that edit, we really should have documentation there. So that's always a great point of provider education. Okay, that's it for the NCCI edits and the NCCI manual for 2025. But I did want to do a little bit about the 76937 reversal, just in case you missed it. And I use my little cool acronym that all the kids are using these days. But in case you missed it, let's talk a little bit about what happened last year in case, again, you missed it. So CMS did reverse course on CPT code 76937. And when we're talking about 76937, it is an add-on code for ultrasound guidance, vascular access, requiring evaluation of potential sites, vessel patency, needle entry, and it needs to have a record and a report. So in 2024, when CMS published the NCCI policy manual, they added 76937 to policy statements like this one. So it says radiological supervision and interpretation codes include all radiological services necessary to complete the service. And then they go on to say this includes CPT codes for fluoroscopy, and said, for example, 76000, 77002, 77003. Then what they added was or ultrasound guidance 76942, 76998, and then they added 76937 shall now be reported. So basically what they were saying is 76937 was going to be generally accepted as being inclusive to a lot of procedures that it wasn't previously. So needless to say, this kind of caused an uproar, to say the least. I know a lot of societies got involved. I know there was a lot of discussion on CMS's side. I know there was a lot of discussion about this. CMS came out on February 14th as a little Valentine's Day present and said, we changed our mind. We're reversing our decision. Please move forward with coding 76937 as you normally would. So needless to say, I would say that 76937 is maybe on the radar of CMS as something that may be overcoded. So if you're a person who is coding a lot of these types of procedures, something with in the cardiac area, maybe your practitioner is a cardiac surgeon or something like that, really go back to your guidelines about 76937 and make sure that you're coding it appropriately. I know there's a lot of great references out there that if you really need to dig deeper on this, but just know that you can add it if you were using your NCCI manual from last year and you didn't realize that it was removed. You definitely can code it. It's not considered inclusive across the board, but you do need to be careful of when you use it. So it's applicable with procedures such as embolization, selected catheter placement, dialysis circuit access. And to really code the code, it must include pre-access assessment of venous patency and real-time visualization of needle passage. It must have permanent recorded images of vascular access site in the patient record, and it must include the documented description in the procedure report. So when would you not use it? So you really wouldn't use it in cases where the ultrasound is used solely to locate a vein, or maybe to mark a skin entry point, perform a puncture without guidance, something like that. It really generally would not be suitable to use that 76937 code, but it's just something to be aware of. Again, there was a lot of discussion about it. They did reverse course, but I still really would be careful using that code and making sure that the documentation is really there. Before we wrap up, I did want to just talk about a little bit of the references. The Medicare NCCI manual is a great reference. Like I said, always check and make sure that this is something you really should be referencing at your facility. But it's on the CMS website. It's a download per body system. So you'll have a download for the 10,000 code, you'll have a download for the 20,000 codes, but it's a great reference. I have it on my desktop at all times. All of the information about the additions, deletions, and revisions is on the CMS website. Again, I have a download for the outpatient as well as the practitioner edits. Like I said, there are differences. There aren't a ton of differences, but it's important to download the correct one for whichever place that you're working. If you're interested in looking at any of the additions or deletions for added or deleted codes, you can always download those, but usually those are pretty self-explanatory. And then I did have the MLN fact sheet here on the proper use of modifier 59, XE, XP, XS, and XU. That is one of my favorite references. Like I said, I have that on my desktop. I use it all the time. It's super important to use those codes appropriately.